Hello, Assalamu alaikum wa rahmatullahi wa barakatuh. I am Dr. Ghulam consultant anesthetist, Prince Muhammad bin Abdulaziz Hospital, Riyadh. Today I will present the ankle block. Ankle block is indicated for procedures distal to the MEDIAL. It's a purely sensory block and it's a commoner nerve block. This is more because of the superficial location of the nerves. It is very painful to perform the ankle block. There are three techniques used for the blocks. The most common technique nowadays is most favorable technique is ultrasound guided blocks. And the second, which is acceptable in landmark technique, which is commonly used in areas where ultrasound are not available, and it gives good results because of the easy landmarks. The nerve stimulator third technique is nerve stimulator technique. Nerve stimulator technique is not used for ankle block because these are 3 nerves out of 5 are superficial, supplying only skin, so has no value in this block. Conscious sedation may be required, but don't over sedate the patient. Second, ankle block involves the blockage of 5 nerves on priority basis. I will name the nerves according to priority. The first nerve to be blocked is tibial, which is thickest and deeper and needs long time to be anesthetized, so it should be blocked first. And then the second nerve, which is deep and thicker also, is deep peroneal nerve. The third, fourth and fifth nerve are superficial and cutaneous nerves, and the very easy to remember, all starts with S and all supplies with the skin. And so the third nerve is superficial peroneal nerve. There is SAPHENOUS nerve and SURAL nerve. This diagram shows the distribution of the cutaneous distribution in the foot. In the plantar surface of the foot, you can see the color, 3 colors are dominant, and all 3 are the branches of the posterior tibial nerve, which are, first branch is calcaneal nerve, the second branch is which supplies the heel, the second branch is green in color and it's lateral plantar nerve, the third branch is medial plantar nerve, which supplied big toe 3.5 digits on the plantar surface of the foot. On the dorsal surface of the foot, the yellow color is dominant. It is superficial peroneal nerve, which is supplying the almost all of the dorsum of the foot. On the lateral side, some part is orange, which is supplied by the SURAL nerve. On the medial side, it's SAPHENOUS nerve, which supplies to the base of the big toe. There is the 1/4 nerve, which is deep peroneal nerve, which supplies the first interdigital space between the big toe and first toe, is web space. This is the cutaneous distribution of the nerve supplying the ankle. Now, anatomy of the tibial nerve. First nerve. Tibial nerve is very easy to identify. Actually, this is called the peri-arterial technique. Artery is easy to palpate the arteries, and posterior to the artery, near to the tendon of Achilles, or sometimes rarely it is posterior or anterior to the artery, and it varies. And this is the reason of failure of ankle block and landmark technique. So if we identify the medial malleolus, if we go behind the malleolus, we can identify the posterior tibial artery easily, and posterior to the posterior tibial artery, most of the cases the nerve is available, and you can find in this diagram. In this diagram you can see the artery easily, and posterior to the artery is posterior tibial nerve. It has a long duration, long distance, almost same position posterior to the posterior tibial artery. This is commonest anatomical location of the nerve. It can vary in rare situation. This is the plantar surface of the foot and the medial side of the ankle, and you can find the position of the nerve, which is almost fixed posterior to the posterior tibial artery. As soon as it enters the ankle, it gives the calcaneal branch which supplies the calcaneus, and then gives the lateral plantar and medial plantar. This is a sonoanatomy of the posterior tibial nerve, tibial nerve you can say. Putting the ultrasound on the medial side of the tibia, touching the tendon of Achilles, you can find easily the palpable artery, palpable and visible artery. If you go to the color Doppler, you can find it easily, and in this diagram you can find very easily the posterior tibial artery and nerve. And this is another diagram showing the practically application of the tibial nerve. You can find the needle going from the posterior side towards the tibia, and this is the in-plane technique showing the tibial nerve posterior to the tibial artery. So we should always avoid passing through the tendon of Achilles, which is not recommended. We should go above the tendon of Achilles through the skin and very near. In landmark technique, we go through this port, this side, and touch the tibia and just pull the back needle for a few millimeters. Aspirate. If there is no blood, we can inject 8 to 10 ml in blind technique. While in ultrasound technique, we have to make a donut which may be caused by 3 or 4 or sometimes 5 ml of local anesthetic solution. The second most important nerve, which is thicker, is the deep peroneal nerve. It is the extension of the common peroneal nerve and enters the ankle between the flexor hallucis longus and extensor digitorum longus muscle. And in this slide you can see it easily. This is the anatomy of the dorsal spadius artery and this deep peroneal nerve. You see this nerve is continuously lateral to the artery, and dorsal spadius artery is easily palpable. If any place, if you find that this dorsal spadius artery, we can inject 5 ml of local anesthetic blindly. It's easy to block. Then we can use the ultrasound technique, and we can identify and make a donut around the nerve, and it can be blocked by 3 to 5 ml. This is the landmark. You can find the anatomy easily accessible. You can find the nerve position, which is between the tendon of extensor digitorum longus and extensor hallucis longus. If we flex the foot, we can find 2 tendons, and between the 2 tendons there is a position of the dorsal spadius and deep peroneal nerve. Deep peroneal nerve provides anesthesia to the first and second rows. It is located between the extensor hallucis longus and extensor digitorum longus. So it supplies only the wave space, small area between the big toe and the small, as we see in the diagram. This is the position in which ultrasound is held, and we can use the in-plane technique or out of plane technique. In this video you can see it is out of plane technique, and we identify the artery, and the needle is coming from direct in line out of plane to the nerve, very easy to identify and inject. This is the diagram showing the bony landmark of the bones of the foot, and you can easily identify the pulsating artery, and lateral to the artery is nerve. This is the slide showing the donut formation around the deep peroneal nerve, and 3 to 5 ml is enough to make this donut. Third nerve to be blocked is the superficial peroneal nerve, and it supplies the skin, most of the skin of the dorsum of the foot, and very easy to block, and we don't need even ultrasound for blocking of this. This nerve is very rarely visible on ultrasound. If you go higher in the leg, we can find above the foot, above the malleolus, we can find the deeper superficial peroneal nerve, but there is no need of identifying the nerve, and just injecting 5 ml between the two malleoli is enough. Just raising a wheel between the medial malleolus and lateral malleolus subcutaneous is enough to block this nerve, and it's usually given by a landmark technique. Identify the medial border of the medial malleolus and the medial border of the lateral malleolus. Just raise the skin wheel, it's enough. It's usually blocked. And in the next diagram you can see the area supply of the superficial peroneal nerve. The fourth nerve to be blocked is sural nerve. You can see the anatomy of the sural nerve, and it is the extension of the tibial nerve, and it enters the foot between the tendon of Achilles and lateral malleolus. Blocking the sural nerve. Identifying the lateral malleolus and Achilles tendon, insert needle superficially lateral to the tendon and in the direction of the lateral malleolus. Inject 5 to 10 ml of local anesthetic subcutaneously and withdraw the needle. So it's enough to block the sural nerve. Sural nerve is also not visible usually on the ultrasound, but we use this landmark technique in this. And this nerve has a good location. It's always under the small saphenous vein, and this is also called perivenous technique. And in this diagram you can see how the drug is injected between the tube bone and the small saphenous vein. And in this diagram you can see easily it's always accompanying the small saphenous vein. And in this again sonoanatomy, how to put the ultrasound probe, and it's easily identifiable. Sometimes it's not visible because very thin, and both techniques are used. There are experts who can locate the sural nerve from very beginning till the end. The saphenous nerve is the fifth nerve to be blocked in the ankle. This is the terminal branch of the femoral nerve located anterior to the medial malleolus. This supplies the medial part of the foot up to the base of big toe. This is my foot, and this is my ultrasound. I am holding the ultrasound, and you can see in the next diagram how it is visible. This is my tibia, and this blue is my saphenous vein, and between the tibia and the saphenous vein is a white structure. This is the saphenous nerve. It provides sensation to anterior medial side of the foot. Blocking the saphenous nerve is very easy. It's injecting 3 to 5 ml of local anesthetic drug solution below the great saphenous vein. That means between the saphenous nerve and the bone, and we are done. Equipment required are betadine, uncoil wipes, sterile gloves, 4x4, 2x2, sterile towel, 5 syringes of 5 ml with local anesthetic, 25 gauge needle, 1.2, 1.5 inch needle. So in blind landmark technique we can use the ordinary syringes 10 cc for 3 nerves. What we do is to prepare 5 syringes with 5 ml, 10 cc syringes containing 5 ml in each syringe. So it is 0.4% solution used for the easiness of the user. And if you use ultrasound, 5 ml is enough, and for every nerve. So 20 ml is used in 70 kg person, which is less than 3 milligram per kg, and in the standard dose. And there are different local anesthetic which can be used depending on the duration of action required, and we never use epinephrine in these blocks. These are the local anesthetic agents used in this block. The most important thing is every block needs more than 10 minutes and up to 20 minutes to be effective. So this is again a trick. Don't go in hurry when you give the block. Leave the patient alone for 15 to 20 minutes, even 30 minutes. It works well. Let the drug distribute inside the body and inside the nerve, core and mental. And it's again a trick of successful block to give time half hour. If you block the nerves, and that is the reason I emphasize on blocking first the tibial nerve, then posterior tibial nerve, then the peroneal nerve, then superficial peroneal, then SURAL and SAPHENOUS. The last three, superficial and cutaneous nerve, may be blocked. Anyone may be blocked before any nerve, but the first and second should be blocked first. So this is most important. The duration of action is very long, and we usually use bupivacaine, and it works for more than 12 hours. Patient is pain-free, and be careful. A special consideration of be careful with vascular disease and diabetes mellitus. Patient with infection, there's a risk of tracking infection to healthy tissue. Local anesthetic do not work in acidotic environment, and edema and sepsis, swollen limbs, it is not effective. Position of foot depends on the choice of the anesthetist. Usually we make 4 position or whichever is suitable to you. Complication is discomfort to the patient. This is very painful procedure, so the patient is discomfort. There is a solution to use, I will discuss, to use the sedation like ketamine 1/4 milligram per kg, midazolam in small doses 1 milligram per kg in 70 kg, which causes sedation, not too much. The patient can chat with you, but it keeps the patient comfortable. Injury to a numb foot after discharge. Patient is numb for 15 hours, sometimes 18 hours, and he start walking, so he may injure his foot. Nerve injury or paresthesia. The drug may be injected internally and can cause paresthesia. There is chances of hematoma formation and vascular injury. There are chances of infection, so meticulous aseptic technique should be used. There are chances of intravascular injection by mistake, and the block may be failed sometimes. Ephedrine should not be added to the solution. Key to successful block. One must be master of anatomy. Anatomy is variable, so ultrasound guided is solution to variable anatomy. It gives you perfection, increase the success rate. Needle must be visualized clearly, especially cut tip, and 5 ml solution injected around the 5 nerves, making donut. Conclusion: easy to administer, effective analgesia, often performed with much less local anesthetic, what is mentioned in the textbooks. Trick of trade: these blocks are usually performed in diabetic foot, and they are already have the sensory neuropathy. They are not feeling pain, so it works well in diabetics. And second is keep the patient sedated with midazolam and ketamine 1/4 milligram per kg, and it's very good somatic analgesia. So in conclusion, the 5 nerves, 2 are periarterial nerves, which are major nerves. This is posterior tibial, is posterior to the tibial artery.
very easy to identify. The second periarterial is dorsalis pedis artery. It is deep peroneal nerve, which is lateral to the dorsalis pedis artery, very easily identifiable, palpable. Artery is always palpable usually, and the all three techniques, which are all three nerve remaining, is superficial peroneal, deep peroneal, and SURAL nerve, which are cutaneous nerve. Two are perivenous. Just put 5 ml below the saphenous, great saphenous one nerve, and 5 ml below the small saphenous. Your both nerves are done. The last nerve to be blocked is between the two malleoli. Inject the wheel, raise the wheel of 5 ml with 5 ml of local anesthetic, and you are done. So don't hesitate to use block, ankle block in minor surgery. This is the most commonly performed block, and diabetic foot comes to us very often, so there is no need of giving GA. GA is risky to this uncontrolled diabetic patient, so please go for ankle block. Just remember 2 5 ml below the great saphenous vein, 5 ml below the small saphenous vein, 5 ml between the two alveoli, between the two malleoli, and then dorsalis lateral to the 5 ml lateral to the dorsalis artery, 5 ml posterior to the posterior tibial artery. That's enough. You don't need ultrasound, you don't need any help. Just 10 cc syringe, 10 cc syringe, and 25 ml of local anesthetic solution, sterile or aseptic technique. That's all. And if you have ultrasound, you have a precise approach, and you can block with even low volumes of the local anesthetic. Thank you very much. Please subscribe my videos and like it and share it with your friends. Thank you very much.